Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. Let's talk about risks and liabilities of taking an orthodontic patient with a history of generalized root resorption, but no periodontal disease, and no endodontic disease, and no fillings, and no to pretty much no trauma. Like, why, if you're looking at this, I encourage you to watch this video with video so you can see what I'm looking at. Look, I see this stuff all the time. And so my first question is, has this patient had orthodontic treatment before? But let's say this was a 12-year-old. Now, probably not. Clearly, their teeth are crooked. How did this happen? I mean, look at the upper right five. I mean, look at the upper left five. I tend to see it more in the premolar area. That's where it's usually worse. Sometimes in the incisors and premolars. So let's go into this. What can cause this, and what do you do if you don't know how many times I see one of these like every week. I mean, they're so common with my doctors, and a lot of times the doctors don't notice it. They don't read the panel, and sometimes they've collected down payments or full payments in full for the Invisalign the braces. I'm like, you can't do that. Give it back. You're not treating this case. And they get upset, and I'm like, you're not taking this case. It's not getting ortho. They'll all fall out. So let's talk about this a little more. What causes this? And this is going to be a long video. So, okay. So I had to go back to my dental school memory and read some textbooks and read a lot of literature to get caught up on this. So, basically, we're talking about G.I.R.R. or Generalized Idiopathic Root Resorption, often referred in the clinical literature as multiple idiopathic external apical root resorption, or MIERARR, or multiple cervical resorption. It's a rare and complex dental condition where the body's own cells break down and absorb the root structure without an identifiable cause. So it stinks. And to be honest, I very well may have this. I have like no roots on multiple teeth, but I had a lot of orthodontics, and I remember them being very strong forces. So I don't know if mine was this or if it was due to just bad ortho. So I'm chalking mine up for bad ortho, just based on what I know. But yeah, if this person had never had orthodontics, never been in major trauma like car accident or anything like that, doesn't have a lot of fillings or decay or any on those teeth, it could be GIRR. So how does this present? So first of all, the point of GIRR is that it's steady. Nobody knows they had it. There won't be any pain or anything like that. No symptoms. The only way you're going to know is you take the x-ray and you're like, oh no. It's usually a surprise during x-rays. Surprise. That's what happened to me. I remember it. As I remember, we were learning to take we were in radiology clinic first year, D1s, and we were taking on each other and we were developing them. And the person who was developing mine, my partner, was like, what? And they looked so upset. They didn't know what to say, because we were finding cavities and people would have something small, right? Occasionally a little pathology, but I had like the worst pathology. And I was like, I didn't know. So over time, these cells will shorten, and then round off. And eventually they'll get loosed and wiggle out. So it usually keeps going. That's part of the hallmark of it. You've got an apical one, which is like what this one is. It starts at the apex, moves, gets blunted, and moves up until we just have like a nubbin. And then there's a cervical one, which goes more inward and kind of explodes the tooth from the inside out. It's very sad. I've seen both. In terms of management and treatment strategies, well, first of all, I always like to find out what caused it. So we get into, have you ever had ortho? Obviously, their teeth look pretty straight. They probably had ortho. If the teeth look really bad, they probably have not. But always good to ask. And then, if so, what kind of ortho? How long? How many years? I mean, braces for many years is a dead giveaway. I don't know that I've seen this from aligners for many years, but not at this severity. But braces for many years, I've definitely seen it. Next up, you take a CBCT, you get the report, get it read. So you do all, normal stuff, standard of care stuff. If you don't want to do the next steps, then you can send them to a specialist for next steps. So in terms of specialists, they recommend both perio and endo. I mean, this is a perio and an endo problem. Pick your poison, whatever one you like best. Or you can ask them. So get your CBCT, get a report, then you put them in observation for 6 to 12 months, repeating the CBCT at the end and seeing if there's any change. If there's not any change, at least it's temporarily stable. Doesn't mean it's going to be stable for life. I definitely would not do ortho on these cases. I mean, I'm just laughing because whenever doctors like try to talk me into it, I'm like, you are insane. I said, I'm not helping you with that case. I don't even want to look at it. It's going to be bad. You're going to get sued. Guaranteed. No. So observation, and then of course what I talked about, eliminating any secondary stresses. So we're checking the occlusion, we're making sure we're not hitting high on some teeth, we're equilibrating the teeth, we're making sure we're not doing ortho. That's like the dumbest thing to do. Um, if there are high spots or low spots, then try to get it down by occlusal equilibration. It's just better than moving it. They talk about maybe doing night guards, checking airway. I mean, anything that could cause stress on the teeth or stress in your mouth, cause clenching, cause parafunction. We want to eliminate any chance of clenching, because clenching can definitely cause this. And to be honest, I mean, if you're like a massive clencher, I mean, if you were a super bruxer, I think you could actually do this. So, I mean, maybe people are like super stressed out. I mean, you've seen those people that have the massive masseters when they bite down and they just pop out of their face, and they look like Minecraft faces. You know, if somebody has a Minecraft looking face with their masseters, yeah, maybe they're chewing, they're biting. And then you're gonna have to consider masseter Botox for that. Usually lasts for 6 to 9 months. That would be what I would do: a big dose of masseter Botox, and just kind of titrate it until we get to the point where we're not clenching anymore. Let's see, secondary stress, endodontic therapy if needed. Obviously, you're going to send them to endo, get all the teeth tested. Actually, one of my teeth that had the nub and root, it was like one of these, it ended up dying. It just randomly died. So one day it started aching, and I never had a filling, never had a cavity. It just was going through the root resorption, the generalized root resorption process, and just started hurting. And it wasn't like crazy. And then they tell you about needing a root canal. I would say it was extraordinarily annoying, but it wasn't like I was crying or I needed anything more than just some Motrin. But I think it was a very long, slow death. And I did need a root canal. It had no vitality. But I never got a crown on it. Been 10 years. Nothing happened. Let's see. And then they talked about, yeah, equilibrating, endo, stuff like that. Okay. So you guys get the idea on that. What else? Okay, let's talk about, let's say it's not idiopathic. So the point of G.I.R.R is that we got no idea what's causing it. I don't know. Let's just avoid everything that can stress it out and can make it worse. And just, oh, and also I don't bite on apples or bagels. But granted, my front teeth are like this. They have like no roots. The crown to root ratio to the point where like Perio's like, should we extract these? I'm like, no, they're fine. I don't bite into bagels or apples. They're good. I was told they're going to fall out at age 22, and I'm 52, and they haven't fallen out yet, and they're not loose. So, but I'm very cautious about everything. Okay, so here's some disorders that may cause this. So there are some disorders where this is a symptom or a side effect. So anytime you see one of these, don't just assume it's G.I.R.R. Assume that if you can't figure out what it is, we're sending them also to their physician to try to figure it out. They may not figure it out. If they don't figure it out, it's G.I.R.R. Okay? Hyperparathyroidism. So your patient should go get blood work. And then you'd want to put in the medical referral, please get blood work. Patient may be suffering from G.I.R. We'd like to rule out underlying endocrine and metabolic disorders, you know. And probably the doctor will call you because they don't know what this is. You can explain it to them. Okay, hyperparathyroidism, hypothyroidism, hypophosphatasia. Oh, okay, I didn't even know what that was. Paget's disease, you've heard of that. Papillon-Lefebvre syndrome, it's a genetic syndrome. Turner syndrome, I've heard of that. Goltz syndrome, Stevens-Johnson syndrome, you've probably heard a lot of these. And then medical specialists, I mean, I would just go straight to the primary care. Don't skip over that. But if the primary care is being lame, you're going to need to consult with a pediatric endocrinologist, medical geneticist, or pediatric rheumatologist or immunologist. So, I mean, yeah, all of this just for this. Do not treat, do not move forward. Yeah, and then your endo and your perio. So that's pretty much it. So hopefully that helped you. Keep your eye out for this. It is a sad thing when we see it. But you know, as somebody who's likely suffering from this, it's fine. It's not that big a deal. Just don't do ortho. Just don't do ortho. All right, thanks.